It's going to be live in few seconds. तो मैं
ठीक है।
screen असमा आप YouTube पे चेक कर लीजिएगा।
जी सर, मैं चेक कर रही हूँ। हो गया सर।
Good afternoon, everyone. We'll give just few more minutes. We are expecting few more people to join, so we'll make a start in few minutes. Right, it's 3 past 2 o'clock. Thank you so much, everyone, for joining Hive Medical Academy's webinar. Today's webinar is very important. It's about the hypertension NICE guidelines in PLAB1 case scenarios and PLAB2. So we're going to discuss through these scenarios and these hypertension NICE guidelines today. Before we make a start, just a brief intro of Hive Medical Academy, who we are. Hive Medical Academy is established by NHS professionals, consultants who have decades of experience in medical field. And our team includes local graduates from UK graduates, international medical graduates, and we have got other consultants who have got vast experience in dealing, supporting, and empowering international medical graduate. The overall aim of High Medical Academy is support, facilitate, guide, and empower international medical graduates in NHS career. Hi, today's session. Hypertension in PLAB. What is the PLAB1? You have got the questions about the hypertension cardiovascular system, or it is PLAB2 case where you have got different OSCE stations, management of the hypertension and NICE guidelines. So this is what we're going to take you through today. What you could expect from today's lesson, today's session, you will understand hypertension guidelines, NICE guidelines, what are the latest guidelines, what are the updates, and how you could apply these guidelines in diagnosing, treatment, and management of hypertension in PLAB1 question scenarios and PLAB2 cases and OSCE stations. how you could develop structured clinical reasoning for hypertension scenarios. You have got 8 minutes and how you're going to manage in PLAB2 sessions. And obviously, you will enhance your OSCE skills in lifestyle, counseling, and patient communication. So these are the main objective of the today's session. Fine. What is hypertension? Just overview of hypertension. Hypertension is persistently elevated blood pressure. It could be defined as blood pressure more than 140 over 90 millimeter of mercury in clinic. When patient, you see the patient in the clinic or patient clinic in the ward, it is confirmed by ABPM, ambulatory blood pressure monitor, or home blood pressure monitor. It is very common in the UK. It affects 1 in 4 adults in the UK, a major cardiovascular risk factor for lots of other comorbidities and disease. Early diagnosis and intervention prevent stroke, MI, and renal disease. So you could understand that how important to understand in management of hypertension, all these things. NICE guidelines, they were last updated in 2022. First, they established in August 2019, updated in 2022. What they have introduced, ABPM, ambulatory blood pressure monitor, which is very important, is gold standard for diagnosis of hypertension. And it also advocates for age, ethnicity, and comorbidity based on the treatment. It also promotes lifestyle intervention for all the patients. While we're going through these slides, just keep in mind we are going to refresh your knowledge and we're going to give you a summary of the guidelines and how could you deal it. We're not going to teach you like in a medical school or a medical student because the PLAB questions, the level is should be at FI1, FI2. Right, what's the diagnostic criteria, how you could diagnose the hypertension when patient comes to you? So the different criteria which you have to use. If you're seeing patient in the clinic, blood pressure more than 140 over 90, the next step would be confirmed by ABPM or HbAM, ambulatory blood pressure monitor or home blood pressure monitor system. So you need to find out before you label patient with the hypertension. Then again, you have got you can divide this diagnosis threshold for blood pressure. It could be mild, moderate, severe, or stage 1, stage 2, and stage 3, which is severe. So stage 1 hypertension could be if blood pressure is with the both monitoring systems is more than 135 over 85, and stage 2 with the both monitors like ambulatory blood pressure monitor and home-based blood pressure monitoring system is more than 145 over 95. Then here comes the severe hypertension or third grade is clinic. If patient in the clinic, hypertension more than 180 over 120. And this is the criteria when patient is coming to you and the blood pressure is like that, then that is called as a grade 3 or stage 3 as a severe hypertension. You always need to consider white coat effect and monitor the trends. White coat hypertension, some people they are anxious. They get anxious when they see the patient in hospital, in the clinic, and it is labeled as the white coat because it's just nurses and doctors they used to wear the white coat. So some people, when they go to hospital, they get anxious, but you need to consider those factors as well, that it is not the white coat hypertension. There will come the home blood pressure monitor system, which will help you to diagnose the hypertension. What else you could do once you have got the patient who have got these things? What else? What are other things which you need to consider? Routine investigations you need to consider about full blood count, urea electrolytes, kidney functions. You need to check the urine for any proteinuria, any hematuria, and you need to check the cholesterol, fasting glucose, random blood glucose. ECG, very important. That will give you idea about the left ventricle hypertrophy or arrhythmia. Is there any coexisting factors, any other thing going on? And then fundoscopy. Is there any papillary edema, visual symptoms, or long-standing hypertension? These will be very common in patients. Asymptomatic patient who had hypertension long-standing, but they will have some symptoms like visual symptoms, which will you could confirm by the fundoscopy. By treatment algorithm, most important step one, stage one is the lifestyle. You have to advise all patients. Patient education awareness is very important. First step will be the lifestyle advice, and second, then you will start the medication. NICE guidelines, they have changed around 4 or 5 years before. Before it was used to be less than 55 and more than 55, less than 55, they were used to have ABCD. and now they have changed to ACD. Less than 55 non-African or black patients, you will go for the ACE inhibitors or angiotensin 2 receptor blockers, which are ACE inhibitors are enalapril, ramipril, and S2 blockers are the valsartan, telmisartan, all those things. And if somebody is more than 55, Black, African, Caribbean, then you will make a first choice of the drug will be the calcium channel blockers. In step three, what you will do, you will add another drug. That will be like if somebody is already on ACE inhibitor, you will add the calcium channel blocker. And step four will be another addition of another drug to control the blood pressure. If blood pressure is still not controlled, still not in within the limits, then you will add diuretics. So step one, less than 55 ACE inhibitors or ACE2, age more than 55 or black, you will go for a first choice of drug is the calcium channel blockers. Then step three, if still blood pressure needs controlling, you will add the calcium channel blockers. And step four, you will add thiazide diuretics. And you need to continue to monitor the blood pressure, review the patient regularly, and you can optimize the medication, the dose of the all medications. Lifestyle advice is very important. Nice guidelines, they emphasize on the lifestyle because this is one of the reversible factor in cardiovascular risk. Family history, which is irreversible, but there are some reversible factors and lifestyle advice comes in reversible factors, which you could make a difference in patients. So weight reduction should be less than 25 BMI, reduced salt intake, regular aerobic exercise is brisk walking, cycling, swimming, jumping, dancing. All this comes under aerobic exercises. So regular advise the patients to do these aerobic exercises, moderation of the alcohol and caffeine. Smoking cessation, very important, and dietary approach to stop hypertension, very important. Plenty of fruits and vegetables, regular walk, low-fat dietary, and reduce saturated fat. These are the lifestyle advices which are very important for any patient who is at risk of the hypertension or who has come to you and the potential risk of getting the more cardiovascular disease. Quickly, we'll go through a scenario, PLAB1, what sort of the questions you could get in the PLAB1. This is the typical scenario, typical question, exemplary question from the PLAB1. 55-year-old man presents to his GP for a routine checkup. He has no symptoms but has a BMI of 32 and family history of hypertension. His blood pressure reading our three visits average 152 over 96. He does not smoke and he has no diabetes or CKD, chronic kidney disease. What's the most appropriate next step in the management? So you'll get the options like start amlodipine, lifestyle advice, and repeat BP in 3 months. Preference for urgent echocardiogram or start ramipril. The fifth option is 24-hour ambulatory BP monitoring. Fine. So please feel free to drop in a chat box if you want to answer, choose your answer. Few things, if we look at the scenario, there are few things which are very important to consider. So first thing you will come to know when you're reading this scenario, he has no symptoms, but he has BMI of 32. So one thing he's obese, he's overweight. And second risk, this is the reversible factor. Second reversible factor, he has a family history of hypertension. So two factors. And other thing is blood pressure is constantly high. Good things in the scenario, he does not smoke, no previous comorbidities, other diabetes or chronic kidney disease. So these are very important things to consider whenever you're reading a scenario for the PLAB1. Always think about these things. This patient, 55-year-old, he has got high risk. He's overweight. His second high risk is his family history of heart cardiovascular disease. Third red flag or third risk is his blood pressure is constantly high. Then he has a good thing that is no previous comorbidities. So anybody want to answer? What could be the answer? If you want, please feel free to answer. What option would you go as you start amlodipine, lifestyle advice, or repeat BP in 3 months, refer for urgent echocardiogram, start ramipril, or 24-hour ambulatory blood pressure monitoring. Anybody wants to, please feel free to speak, unmute yourself, and if you want to give the answer. No? All right. So let's move. The best answer would be E, 24-hour ambulatory BP monitoring. Because before we start any treatment, we need to diagnose. We can't label any patient without justification, without the diagnosis. We should have evidence that yes, this patient has got hypertension, and we should have evidence for that. And that evidence will come when you will monitor patient's blood pressure for 24 hours. That will give you variety of the reading and ideas that yes, this patient's blood pressure is constantly high. Then you will focus on other things. What would be the next step? Next steps would come for dietary advice. Obviously, we reduce his weight. That's very important. And to reduce the blood pressure, we could start at the next step to medication. He's 55 year old, and you can start with ACE inhibitors. So why we chose this one? As I said, this is very important to diagnose the patient before we start on medication or before we take any other step. And again, in this situation, patient's blood pressure was high in the clinic. Whenever he came to see the doctor, his blood pressure was high. We don't know. We need to rule out either it's the white coat hypertension or it is the anxiety, stress. When he comes to the hospital, his blood pressure high. Maybe when you check his blood pressure when he's at home with the ambulatory BP monitoring, his blood pressure could be normal. So you could understand why it is very important to investigate and diagnose properly before you start patient or label patient with hypertension or start any medication. As I said, lifestyle advice is very important, but not the only step. eh? It will change. Obviously, you will advise them to lose their weight, salt reduction, exercise, alcohol reduction. It is very important to monitor blood pressure, bringing the blood pressure less than 150 over 95. And ABPM will be the first choice to do this and to confirm the hypertension before deciding on long-term management. Because once you start the medication, it will be very hard. Either blood pressure is reducing because of medication or just because you were stressed in the clinic and there are other comorbidities or there are other factors. Again, as the drug, starting the drugs is not the first choice because we need to confirm the diagnosis and the echocardiogram because we don't know that is this patient has got hypertension or it is something else. So first we need to diagnose. Once patient has been diagnosed and confirmed, then we could go for echocardiogram and we can see on the ECG as well either there is a hypertension, LV hypertrophy or other complications. Then we'll go for the echocardiogram to find out about heart failure, hypertrophy, or other things. All right, so key learning, very important. Everybody who is taking the PLAB, they must go through the NICE guidelines and CKS guidelines. These are very important. And stage 1 hypertension, diagnostic criteria, blood pressure more than 150, 140 over 90, confirmed with, again, with ambulatory blood pressure and home blood pressure monitor. Stage 2 hypertension, if blood pressure reaches more than 160 over 100, you need to start the treatment if it is confirmed. When to start medication, right? Once you have got the confirmed diagnosis by ambulatory blood pressure, average is 135 or 85, or home blood pressure monitor is 135 over 85. Start antihypertension, and we know if less than 55, ACE inhibitors. Next step, calcium channel blockers. And if more than 55, and you can go for more than 55 Afro-Caribbean, you will go for the calcium channel blockers, and then you can top up all these medications. You can optimize medication dose to control the blood pressure. Lifestyle advice is very, very important. It's not just you could ignore it because this is very important for the patient education and for the reducing the reversible factors and reversible risk factors. Right. Common scenario you can get in the PLAB1, you will have the scenario like patient with coming with a BP of 140 to 92 asymptomatic. What could you do the next step? The question could be, option would be, what will be the next step? Like you had one simple question. And if patient's BP is 170, what you will do the next step? So you will start antihypertensive plus ambulatory blood pressure because 170 or 105 is a very high blood pressure that could take you hemorrhage or other things. And if BP is 188, 112, urgent treatment of hypertension required. 130, 80, diabetic, a patient is diabetic, so he has got one comorbidity or risk factor and extra red flag. So lifestyle advice to target blood pressure less than 130 over 80 in diabetic patients. These are the nice guidelines, and these are very good, very important. You memorize all these nice guidelines. Right, we have got the PLAB2, and I think at this stage I'm going to hand over to Dr. Umar. I think he's going to take over from here, and then we'll start. I think he's going to take you through your PLAB2 scenarios about what sort of the scenarios, what sort of the cases of the hypertension will be in the PLAB2, and how you could deal in 8 minutes and 90 seconds you will have for your reading the scenario, and 8 minutes you will have for the to deal with the situation inside the in the OSCE station in with the examiner. Right, so over to you, Dr. Umar. We could see your screen. So yeah, over to you now.
Thank you, Dr. Keel. Good afternoon, everyone. Thank you for joining. Obviously we're speaking about hypertension today in PLAB2, obviously OSCE examinations, slightly different approach. You don't just have to consider, what do the guidelines say? You have to also deal with and respond to the patient and the person in front of you who's asking you things, who maybe has things they're worried about, things they're openly worried about, things they're secretly worried about, and so you have to deal with all of that in your OSCE station. So, as a reminder, PLAB2 stations, 90 seconds to read the scenario, and then 8 minutes to complete the task inside of the room. So, in hypertension, what kind of stations are you likely to get? So, it's likely to be history taking or an explanation station or history taking and management combined. So that's the type of station you're likely to get. And here's one type of scenario you could come across. So just an example for us to work through, so we can pick up some key points, some key learning points. So you're a junior doctor in general practice. Usually this will say you're an FY2 in GP surgery. Mr. Smith, a 58-year-old man, has come for a routine checkup. His recent clinic blood pressure was 154/96. Take a focused history, explain the diagnosis, and discuss management. So usually in the exam, the actual wording of the scenario is even less specific than this. But we're just using this just to tease out some more points for you. But in the PLAB2 exam, it will say something like you're an FY2 doctor in general practice. Mr. Smith is 58 years old. He's come for a routine checkup. Please proceed as appropriate. It will be more likely to say something like that. And then you have to go inside. Of course, what do you need to do after the usual pleasantries of introducing yourself, explaining who you are, checking the patient's details? Then you would need to proceed to take a history. Now, obviously, if you have some information already from the scenario, and you can be a bit more focused. If not, then you need to be very broad. But what would you be expected to do in this kind of scenario? So, of course, in the history, what kind of things are you going to want to know? Are you going to want to explore patients' lifestyle, what their diet is like, including things like salt, alcohol, as well as the types of foods that they tend to eat, sugar intake, all of them kind of things are relevant. Of course, smoking, exercise is all important as well. In hypertensive patients, you do need to check for certain symptoms, particularly symptoms of end organ damage. If they've been hypertensive for a while, perhaps undiagnosed, so headaches, visual changes. Are they getting any other symptoms of cardiovascular disease or chest pain, shortness of breath? Of course, risk factors are important, family history um, of any cardiovascular conditions, or do they themselves have any diabetes or CKD? So of course, let's not forget the three domains, the main domains in PLAB2 is data gathering, which is all your history taking plus any examination that you need to do. Then there is clinical management, which is kind of the second half of the consultation. And then you have interpersonal, which covers things like communication skills, professionalism, etc. And that runs through the whole consultation. Obviously, you're going to need to explain um, to the patient, or you're going to need to discuss some options, give some explanation, explain what you need to do next. So, in a discussion, what kind of things are you going to need to explore? We've mentioned salt, less than 6 grams per day. Ideally, you're going to need to encourage exercise, see what they're doing already, see if you can encourage them to do more or more frequently if they're not perhaps doing quite enough. Alcohol, it's important to mention what the current guidelines are regarding safe intake, which for males and females both now is less than 14 units per week. Medication, of course, might need to be discussed once, it might be something that you discuss in this particular scenario. It might be discussed if the patient already is on some medication, or of course, as we've just heard, according to the NICE guidelines, that the diagnosis has been confirmed by ambulatory blood pressure monitoring or home blood pressure monitoring. So you'll need to explain, might need to start some medication, and then explain why as well. Why is medication important, and why is hypertension an important condition? We need to explain about cardiovascular risks of heart attack, stroke, etc. Follow-up is important as well. We need to address things like keeping an eye on the blood pressure, and perhaps even and even adjusting medication doses also. So we've mentioned that there's three main domains, but these can be broken down a little bit further as well. So in history taking, obviously, apart from just the lifestyle, food intake, etc., we need to ask about other risk factors, family history, any symptoms the patient is having. Perhaps we can, explore things like stress as well, psychosocial. The psychosocial aspects of consultations is really important. That's one of the key pillars that we teach our PLAB2 students about. ICE is important. We need to get into the mind of the patient. We need to understand what they've been thinking about, what their worries are, what their concerns are, what kind of things are they expecting. So that's another pillar. And of course, red flags we've already mentioned. Things like symptoms, worrying symptoms as well, chest pain, headache, visual symptoms, etc. Communication is important. We need to make sure that we use as little jargon as possible, particularly at the beginning when things are new for patients. We need to demonstrate our clinical reasoning. So we need to demonstrate if, for example, we need to we need to make a confirm a diagnosis using ambulatory blood pressure monitoring or home blood pressure monitoring. We need to explain why that is. We need to explain why we need to do certain investigations. So, why do we need to do certain blood tests? Why do we need to consider other things? We need to explain. Um, uh, Perhaps that we're looking for, we making sure that we're ruling out any secondary causes of hypertension. Of course, the vast majority of hypertension is what we call essential hypertension, but we need to explain that sometimes, we need to uh, we need to rule out other causes like renal causes, as well as end organ damage as well. In the management part, we need to advise lifestyle changes. We need to discuss the possibility of medication. We need to revisit them things that came up in the first part of the consultation, perhaps things that the patient was worried about, things they wanted to explore, whether that was fear of medication, fear of side effects, discussions about the risks of hypertension, all of these kind of things do need to be brought back in the second part of the consultation. So common pitfalls to avoid. So obviously we've been through the NICE guidelines. We know that you need to confirm the presence of confirm the diagnosis of hypertension with either ABPM or HBPM without jumping to medication. We can't just focus on drugs alone. We have to make clear the importance of lifestyle and doing things like not addressing concerns, or perhaps even if I can go further than that, not even actually exploring concerns of the patient. So not doing the ICE itself. So for PLAB2, similar to PLAB1, you need to have the diagnosis confirmed first. Lifestyle advice is, gets the way you explain, the way you counsel, the way you motivate patients about their lifestyle can pick you up a lot of marks. And demonstrating, things like empathy in that interpersonal domain. Putting yourself in the patient's shoes, saying things like, I understand your concern about medication, or I understand why you're worried. Let's discuss that. These kind of things will be very important for you. So, um, the next couple of slides demonstrate how these key points can be broken down on a mark scheme. Exploring the context of the presentation, screening for symptoms of end organ damage, checking certain symptoms, exploring lifestyle, exploring risk factors, comorbidities. And then in clinical knowledge and diagnosis, we've already explained, the explaining the need for monitoring to confirm hypertension, mentioning why that's important, what's the difference between white coat and sustained hypertension, and ruling out other causes if relevant. And the examiner will take note of the way you listen, the way you explore things, and the way you explain everything as well. Is it pitched at an appropriate level for the patient? Is it low on jargon? Um, and depending on the particular scenario, were certain things missed or omitted, or did you include them? In management, again, this just demonstrating all the things we've already discussed, but that how the marks can be broken down and how each point is extremely important. Again, things like using jargon-free language, addressing the patient's concerns, shared decision making. We in the management part of the consultation, it's important to ensure that we're not just dictating to the patient, but we're actually taking on board their concerns as well, but not in a tick box way, not just checking ice just for the sake of checking ice, but actually then bringing that discussion back in the second part and making that part of the conversation in the second part, so that you can have a two-way discussion about the pros or cons of treatment. What would happen if we didn't treat? What are the benefits of treating, etc. The use of open questions. These kind of things are what we need to encourage. We've already mentioned red flags. You need to even in these kind of stations, counseling, explanation stations, the importance of checking red flags is key, and that they are one of the three pillars that we mentioned. Red flags, psychosocial context, and red flags, psychosocial, and ICE. So, of course, in terms of whether you pass or fail the station, you will get what's called a global rating. So it'll either be a pass, or a fail, or uh, a clear pass, or a narrow pass. And so it's important um, to not just get bogged down in the specifics of certain cases that you might see that are shared in groups that are, in this case, do this, and in this case, make sure you do this. That's not what we try to encourage. What we try to encourage are things that will prepare you for any kind of station, any scenario that you're faced with. So we try to build skills, not scripts. You do need structure, of course, so you do need to have a structure because there are certain things that you need to be able to fall back on. Sometimes you go blank in exams, so that a structure is important. But we don't encourage memorized scripts or memorizing cases and then tackling them that way, because these cases can change as well, and they do change. They change slightly certain details change, and so that can trip you up. So we've mentioned quite a few times what the guidelines state. We don't need to go over that again. Um, certain mnemonics can be helpful. These kind of things we do encourage. So um, salt, exercise, alcohol. These are mnemonics that can help with covering lifestyle in particular scenarios, like in hypertension. Empathy, as we've mentioned, scores high. Safety netting and follow-up is important. But being specific with that, if you get severe, sustained or regular headaches, or if you get any chest pain, seek help immediately. So not just being vague, like if you feel unwell, make sure you get checked. You have to be specific. So newly diagnosed patient with stage 1 hypertension, you have to take a history. Now, it says focused history, and that's important because you don't have, you can't possibly cover, a full history and review of systems and everything, and have a discussion about ICE, and then also discuss pros and cons of treatment, etc., all in 8 minutes. So certain scenarios, certain cases will be a focused history, and you have to get better at realizing which ones are focused and which ones need a more detailed history taking. Explaining things using clear language, giving lifestyle advice, discussing risks, benefits, and safety netting, and arranging follow-up. Just a reminder of we've already said quite a lot of this, but in the communication part, so in that interpersonal part, ICE is important, empathy, also being holistic as well, which is really important in PLAB2. Sometimes when we come from other health systems, being holistic is not necessarily right at the top of our um, kind of priorities, but it definitely is in the PLAB exam. So taking into account the whole picture. Um, Clinical reasoning, justifying decisions, making sure you're obvious with your red flags and red flag checkings, and professionalism, of course, if certain things come out in scenarios, and most scenarios will usually have some element of either ethics or professionalism in there. Kind of things, again, we've covered this in previous webinars, but things IMGs sometimes tend to struggle with: NHS culture, language, OSCE familiarity, and time management. These are all things that we've focused on, and we make a central part of our PLAB2 courses. So PLAB2 is about safe, patient-centered care. It's not about being perfect. It's not about being an absolute genius at recalling all the possible symptoms or differential diagnoses in a particular condition. It's about being safe, and it's about being patient-centered. So you have to focus on um, that style of communication which we use in the UK, which is polite, is clear, and it's collaborative, which involves the patient. Clinical reasoning, structured clinical reasoning, so asking questions, asking things in the history, but with a purpose, not just for the sake of it, and being able to make that clear. And of course, time is really important. 8 minutes is not a long time. It can go past very quickly. So splitting it roughly 3 to 4 minutes for data gathering, and then 4 minutes for the management discussion is probably a reasonable split. So very briefly, why choose Hive for PLAB2? So we're very good at preparing and delivering OSCE courses. We've been doing it for many, many years. As I've said already, we build skills, not scripts. So no matter what's put in front of you, you won't ever be in a scenario where you don't really know how to proceed. You get daily practice with individual feedback from the most senior members of the team. That's the key part of doing well in OSCEs, getting people to know how to handle these cases, how to speak, how to explore symptoms, how to explain things, getting them to give you feedback. And of course, we've got a range of options available, which go from online, face to face, as well as a variety of a number of days. And we always stick to our promise of if you've joined us once, we'll allow you to prepare until you pass, no matter how many times that is. Hopefully, it'll be your first time, but if not, we'll still be there for you. So that's all. We did want to, we know people's attention spans tend to wane after 30 to 40 minutes. So we wanted to keep it sharp and short, and hopefully we'll try and do more of that in our webinars. And this is just the first of this kind of focusing on clinical scenarios, and we'll do lots more over the coming weeks and months. So thank you very much for listening, guys.
Okay, thank you so much, Dr. Omar. So we are open for any questions from the audience. If there are any question, please just either you unmute yourself and ask question, or you can drop in a chat box.
This is the part when everyone goes shy. That's all.
Uh,
How are you, Dr. Shahid?
thank you, Dr. Shakil, and thank you, Dr. Umar, for a wonderful presentation. I just had a very simple question regarding PLAB2 scenarios. There are so many different types of scenario, different in like eyes, ENT,
Yeah.
cardiology, endo, and everything, the whole range of them.
Yeah.
Sometimes it's not easy for candidates to remember the management, like medication and things like that, for every possible scenario.
Yeah.
What do you suggest in that kind of case?
Dr. Steele, do you want to say something first?
Yeah, I would say, Dr. Shahid, just simply in the PLAB2, they
Yes,
assess how safe you are, how good you are,
right,
how
right,
good your communication with the patient. Even you don't know anything,
right,
but you ask the general question, you put the
right,
patient at the comfort, and you are safe. You don't do any blunders.
right,
If you don't know, say sorry, I don't know, and I'll find out from my senior colleague and come back to you. So while you will be preparing with
right,
us, very unlikely you will get anything which you would not know, because we prepare very well. All
right,
types of scenarios we'll go through, and you will know something. At least
right.
you know how to take history.
Yes,
You know how to be empathetic.
yes,
You know how to be safe, and you know how to
yes,
ask for the help.
right,
And these are most important things to work
right,
in the NHS. If you know these things and you're putting patient at comfort, examiner will pass you.
right.
So, Dr. Umar, you want to add
Okay,
something?
I understand.
Just wanted to add, also, I mean, this is a very common question that PLAB2 candidates ask that, what if what if I can't remember the particular name of the medication or whatever? Then, absolutely, as Dr. Shkil said, just be honest and just say, it's escaped my mind right now. Explain about everything you can remember. And as we
Right,
said, that there's three domains. Okay. We've covered this in previous webinars.
right,
There's data
right,
gathering, there's interpersonal, and there's clinical management.
right.
And the interpersonal part makes up
That's
the
good.
bulk of the marks, 50 to 60%. And then
Right,
the remainder is split between the other
right,
domains. So, of course, if,
right,
ideally, we don't want you to be in a scenario where you can't remember what the name of the medication is, but these things happen. It's best to be honest, say it slipped my mind, but it belongs to this group or this is how it works. Explain as much as you can and say, I'll just check that
right,
and pass you that information. And you're not expected to know exactly, things like dosing, etc. That's not what the examiners are looking for. They're looking for clinicians who can communicate well, who are patient-centered, who are
right,
safe, who don't make up things when they don't know something. and and then they realize the levels of their the limits of their competence. And it's in real practice, of course. We all have access to the BNF at any time.
Right.
And so nobody nowadays expects everybody to remember all the drugs and all the dosing and all that kind of thing. So the bottom line is, the summary is, it could happen sometimes. Don't worry about it. It doesn't necessarily mean you'll fail that station.
Understand. Got it. Thanks.
Yeah.
Yeah. So even you don't know anything, you would know something.
No,
Simple
you
as
will,
that.
you won't,
Yeah.
you will know.
Yeah.
You will have
Yeah.
prepared with us, Dr. Shahid. Don't worry.
Yeah. Don't
You will
worry.
know lots and lots.
But
Don't worry.
even real
Yeah,
scenario, when
thank
you
you.
will be practicing NHS, there will be questions. There will be people, patient coming asking you, "Oh yeah, you're allopathic. Tell me about homeopathic treatment." You would not know. So you
Yes.
need to be
Yes.
honest and tell them. So this
Yes.
is, you know something, always. So there's another question, Dr. Umar.
Yep.
Somebody, if somebody due to stress suffers from a such type of problem, that his esophagus closes during eating and the eating material goes to the air passage. Is this in PLAB1, PLAB2? Why this occurs? Couldn't really. If someone due to stress suffers from such type of problem, what sort of the problem? Could you please, I think this is Tanvir, could you please explain what sort of the problem? If this is a problem that he has esophageal tract is stricture, is something happening, or is he suffering from stress, or is he suffering from hypertension? I think you're not very clear about your question, why this occurs. If esophageal material goes to the trachea, it means there is a stricture, and there is something else happening.
Yeah, I mean, I don't know. It's maybe describing some type of aspiration,
Yeah,
secondary to, I don't know, some condition of the esophagus. Yeah, I mean, potentially this kind of thing could come up in PLAB 1 or PLAB 1 possibly. PLAB 2, I don't think it's
I think it's
it's.
more of a PLAB1 case. Yeah,
Yeah,
PLAB1.
PLAB
yeah,
1
that will be
possibly it
PLAB
might come
1.
up, but if it it's not a very common thing. It's if it does come up, that's one mark out of 180.
Yeah.
So I wouldn't spend too much time worrying about these kind of specific scenarios. Not sure why you asked that specific question.
Yeah.
Maybe it's just something you've come across you don't quite understand. Um, but yeah, certainly not in PLAB 2. In PLAB 2, the kind of split you'll get is you'll get three or four stations that are history taking and management combined. Then you'll get about three procedure stations. You'll get three or four stations that will have some aspect of either explanation or counseling or some ethical consideration. There'll be one prescribing station, most likely, one teaching station. So this kind of thing is not likely to come up in PLAB 2 as a PLAB 1 question, if possible.
Yeah. And possible causing of this thing, if there is a esophageal stricture, eclasia, or you have a fistula between esophagus and trachea. There's so many things that could happen. If food is not going into esophagus, it means it's blocked. Or the stricture, eclasia, or there's a fistula between the two esophageal tracheal fistula. That could happen. So I hope it answers your question. Anybody else has got any question? Please do ask if you have got any questions about PLAB1, PLAB2 scenarios or anything. And if you want to learn more, we have got a free trial. Go on our website and just sign up for the free trial. You have got PLAB1, PLAB2, you have got flashcards, you have got audios, videos, and everything. So make most of these free trial, and you see that will give you the taste of PLAB1 and PLAB2 questions, scenarios, and everything. If there are no more questions, I think we will close and end the session here. Thank you so much, everyone. Thank you so much, Dr. Omar. Thank you so much, Asma, and rest everybody. Thank you, Dr. Shahid, Dr. Isa, Dr. Tanveer, and rest of the participants. Thank you so much for joining. This will be available. Oh, there's some question, I think. No,
No, you're just saying
no.
thanks.
So this webinar will be available on our YouTube as well. If you want to watch later on, I want to share with your colleagues. And all the best wherever stage you are for your PLAB journey, and we're here if you need us. Thank you so much, everyone. Thank you.
Thank you,
Thank
guys.
you.
Speak to you soon.